thing at the bottom. See the thing at the bottom. Tap it again. Tap it again. Wait, look at the thing at the bottom, the icon.
All that background noise is going to come into the recording.
It was there.
That's your mic, Mervin, with the background.
Yeah, I need for everyone to mute.
Steve,
I need for everyone to
in the
mute.
middle, the camera's off.
Yeah, I turned.
Yeah, so that is always. Don't forget about that. That seems to be the issue, not the button.
I need for everyone
That's what
to
I
mute.
keep telling him. Say, I got it. It was on, but him keep on telling me to stop. I told him say it was on, but him.
Can we mute?
No.
Mr. Thompson, can you mute yourself? Okay. Okay, good evening, everyone. We are here. Can everyone see me?
Yes, sir.
Yes.
Okay. So I'm here this evening, and I want to say that Dr. Williamson is ill today. And so I'll be giving this lecture on the pharmacology of substances. And it's a pretty important one. And so I want you all to really pay attention this evening. And if you can get out a piece of paper, because I think that might be useful tonight. What we're going to go over tonight are the classes of substances that are usually causing dependence or addiction, their effects, what you see when you see that you are either overdosed on those substances or when you're experiencing withdrawal for those substances. And so I want to go over a few definitions to get us started, because I think that if you have the definitions, that things will go much better. So I first want to talk about the first definition that we need before moving forward our lecture tonight, and that is dependence. And what dependence is when you become, exactly as said, when you become dependent on the substance. And dependence is usually determined by whether or not, when you take a substance and you start to come off of it, whether or not you get any withdrawal symptoms. So
You're good.
So simply put, what dependence means is when you are accustomed to taking a substance, whether or not you withdraw. Does everyone get that? So dependence is when you take a substance and you take it to an extent that when you come off, that you withdraw from that substance. Another definition that we're going to use tonight is tolerance. And tolerance is slightly different from dependence. Give me a second. So what tolerance means is it's a situation where when you take a substance, or when you start taking a substance, that you need higher and higher amounts of that substance in order to achieve the same effect. Meaning that if you start taking alcohol, you may drink alcohol to a certain amount, but in order to get intoxicated, or in order to get the effects of alcohol, that you need higher and higher amounts of alcohol as you drink. That's what tolerance is. The next definition that we need to know is withdrawal. Withdrawal and withdrawal symptoms means the symptoms and things that happen to you, which we can physically see or we can measure by vital signs of when you come off of a substance.
So go back.
So that's withdrawal. Withdrawal means that when you take a substance, what happens when you come off of a substance suddenly? The signs and symptoms that when you come off of a substance. And overdose is the last definition. Overdose means what happens to you, or what it looks like when you take a substance in an excessive amount. So if you drink too much, what happens to you? If you use too much cocaine, what happens to you? If you use too much opiates, what happens to you? A few other things that I want to go over tonight are some other definitions. So just remember that an antidote is the medication that is used to reverse the effects of a substance. So for example, alcohol as an antidote. Opioids such as methadone have an antidote. So just remember that definition. 3 other definitions. You'll hear me talk about agonists. And what agonists are substances that affect a certain receptor in the brain. Remember, addiction medicine is all about receptors. So an agonist is anything that binds to a receptor. Then there are partial agonists that kind of bind to the receptor, but not 100%. And then there are antagonists. These are substances which bind to the receptor and they're irreversible. So they bind and they don't come off the receptor. Everybody with me? And lastly, we're going to talk about the classes of receptors. So there are certain receptors in the brain that mediate the effects of substances. We have GABA receptors. We have mu receptors. We have CB1 receptors, and we have serotonin 2A receptors. And then there's a certain class of drug which, Patrick, you raising your hand?
Yeah, I would like for you to spell the first word, agonist.
AGONIST. So the agonists, there are partial agonists, and there are antagonists. And then we started talking about the receptors in the brain that mediate the effects of drugs. We have GABA receptors, and I'm going to tell you which receptors mediate which drugs. We have mu receptors, we have CB1 receptors, and we have serotonin 2A receptors. And then there's a class of drugs which has its effects on the brain because it increases dopamine, norepinephrine, or serotonin in the brain. So if you can get all of that correct, you'll be able to get through the lecture that I'm about to give more easily. I'm going to repeat that. So we're going to talk about dependence, tolerance, withdrawal, and overdose. We're going to talk about antidotes. We're going to talk about agonists, partial agonists, and antagonists. And we're going to talk about certain receptors, GABA receptors, mu receptors, CB1 receptors, and serotonin receptors. And we're going to talk about substances like dopamine, norepinephrine, and serotonin in the brain, which cause the effects of a certain drug. So moving on. So on overview again, we're going to talk about the substance classes. In terms of addiction, the classes of drugs that cause addiction are CNS depressants, stimulants, opioids, hallucinogens, and cannabis. We're going to talk in this lecture about the pharmacological effects of each of these drugs. And what I mean by pharmacological effects is how the drugs that we named affect the brain chemistry and behavior, or how these drugs affect essentially receptors. We're going to talk about overdose emergencies. We're going to talk about the signs and symptoms and the immediate response when drugs are used in overdose. We're going to talk about withdrawal symptoms. We're going to talk about what happens to you when you come off a drug suddenly, the signs and symptoms that you see, and how you manage those signs and symptoms by each substance class. And then lastly, we're going to talk about medication-assisted treatment because there are medications that are used to treat certain overdoses or certain addictions or certain dependencies, such as methadone, buprenorphine, and naltrexone. Okay, so everybody got that? So here goes. So the first class of drugs that we want to go over are CNS depressants. The CNS depressants are alcohol, benzodiazepines, and barbiturates. CNS depressants act by binding to GABA receptors in the brain. Remember the GABA receptors? And what they do is they suppress CNS activity, or they make you calmer and sedate and sometimes sleepy. Their effects are through making you sedate, as I said, relaxing you, impairing your coordination, and slowing your breathing down. Some of these drugs, when taken in overdose, can slow your breathing down so much that you don't breathe anymore, and you know what happens when you can't breathe. So the thing that you need to know about CNS depressants is that they are associated with high tolerance. That means that when you start taking CNS depressants, you need more and more of the substance to get the same effect. So people who are dependent on CNS depressants need more and more of the substance to get the same effect. That's why when you see an alcoholic, they need to drink more and more to get the effect that they want. So you find alcoholics who will buy 2 pints one day They do that for 3 months, then they need 3 pints, then they need 6 pints. So CNS depressants cause impaired coordination. So when you think of CNS depression, think about things that cause you to be wobbly, like visually image the drunk individual who can't really stand straight. They also cause, in severe use, respiratory depression. They make it so that their breathing slows down, and if they drink too much of it, they can't breathe at all. In terms of their tolerance and dependence, they rapidly develop tolerance, meaning they need more and more of the drug to reach the same effect. The other thing is that there's cross tolerance. So alcohol, benzodiazepines, and barbiturates, when you use alcohol, you can become tolerant to barbiturates or benzodiazepines. If you use benzodiazepines, you can become tolerant to alcohol and barbiturates. So there's cross tolerance. And in overdose, what you see with CNS depressants are severe respiratory depression. This is why when someone is really alcohol intoxicated, sometimes they bag them because they stop breathing. When someone takes benzodiazepines, they bag them because they stop breathing. And when you combine alcohol, benzodiazepines, and barbiturates, it's even worse. So they can have additive effects where you can have a person that basically becomes so depressed that they don't breathe. And usually the treatment for that is what I did in the emergency room for years is an intubation. The person can't breathe on their own, so you get out the tube and you breathe for them. You intubate them, you put a tube in, and you let the machine breathe for them until the substance wears out in their blood and they can breathe again. Remember, the song "Breathe Again." That's how you remember the situation with CNS depressants. The next drug that we're going to go to is opioids. So there's prescription use of opioids and there's illicit use of opioids. Problem with opioids is that most people got dependent on opioids because doctors prescribed medications. Generally, it was surgeons who would prescribe oxycodones after surgery to relieve pain, hydrocodone to relieve pain, and then people became dependent on the opioids. There's prescription use that causes problems, and then there's illicit use that causes problems. And the illicit opioids that we know is things like heroin and fentanyl, the kinds of things that doctors don't prescribe, but what you get on the street when you become very, very opioid dependent. Opioids bind the mu receptor in the brain. So remember the GABA receptors, right, with the CNS depressants? Opioids differently bind the mu receptors. And when the mu receptors are bound, they inhibit pain perception, right? And they increase reward processing. So, you need more and more of the opioids to get the same effect. The effects of opioids is that they cause pain relief. They make people feel up. Actually, they make people feel good. They sedate people. Now, look at that. They make people feel good, but they sedate them and they make them not feel pain. They also cause respiratory depression, right? They cause you to stop breathing, and they also cause constipation. So if you see someone who's opioid dependent, a lot of times you see them nodding out in the streets. They're very kind of up. They're very good. They're very euphoric when they use opioids. They can feel no pain. They're usually sedate. They're nodding with their eyes closed. They're not breathing as quickly, and they complain of constipation. So opioids have a very high addiction potential, right? And so the addiction potential in opioids is related to their tolerance. So those opioids which are associated with greater and greater tolerance, right? Those opioids which, if you take a little bit of it, you need more and more and more, are related to addiction, right? So some of the opioids don't do it as much, but some of the opioids like fentanyl rapidly causes tolerance, more so than methadone, more so than hydrocodone. In overdose, the reason why people have problems with opioids is that their respirations become depressed. So with an opioid overdose, what we generally did in the emergency department is they would come in, they wouldn't be breathing, their eyes would be closed, they're feeling good, and we need to bag them because we need to support their respirations. Sometimes we need to tube them, particularly if they're on long-acting opioids such as fentanyl and methadone. And then we give them a reversal agent, an antidote called naloxone, which binds to the mu receptors and causes them to wake up. So the scenario with opioids, I've did it for years, is that someone would come in, they found down on the street, not breathing. The medics start to bag them on the way in there. They get into the ED, they put an IV, right? And then we give naloxone via the intranasal route, or we give naloxone IV, and they wake up and they're very agitated because you disrupted their high. Moving on. The next class of drugs is CNS stimulants. CNS stimulants include cocaine, amphetamines, and methamphetamine. And most people, because this is so ubiquitous, most people know CNS stimulants, but it's a little bit more difficult to figure out. Now, CNS stimulants is the only one of these drugs that don't work through a receptor. CNS stimulants are the only class of these drugs that don't work through a receptor. They actually work through increasing chemicals in the brain, such as dopamine, norepinephrine, and serotonin. So you have increased dopamine, norepinephrine, and serotonin in the brain. And they also block reuptake of dopamine, norepinephrine, and serotonin. So there's a lot of norepinephrine, dopamine, and serotonin in the brain, and that's how CNS stimulants take their effects. Give me a second, I gotta turn this phone off. So what do we see with CNS stimulants? We see that people become euphoric or happy. They have increased energy. You know, so if anyone has known a cocaine user, you know, and you remember that they have increased energy. They're running all around the street. It actually enhances their focus. So if you watch someone on cocaine or amphetamines, you notice that they get agitated quickly because it increases their focus. They hear everything and they're overstimulated. You know what I mean? They get stunted really quickly. They're looking up and they're looking around because they hear every little sound. They have an elevated heart rate and they become really anxious. Okay, so there are different types of CNS stimulants, and each of them have different durations of action. The shortest duration of action is cocaine. Cocaine usually lasts from 5 to 30 minutes. So people who use cocaine need to redose over and over and over again because cocaine only lasts 5 to 30 minutes. Then there are amphetamines that last 48 hours. Someone can take some amphetamines, they can wait about 4 to 8 hours before redosing on amphetamines. There are methamphetamines, which have a higher duration. They usually last from 8 to 24 hours. So you can take some methamphetamine and you can have euphoria, increased energy, and enhanced focus for a long time, up to a day. The really tricky thing about CNS stimulants is that their withdrawal effects are different. They're kind of subtle. So someone who's withdrawing from CNS stimulants generally appear depressed, fatigued. They really don't have any sense of joy. And that's how they look. So back in the crack cocaine days at Woodhull Hospital where I worked, we would have all these people who were on cocaine. And when they stopped taking cocaine, they'd be brought into the ED and they would sleep all night. They'd be very unhappy, right? And we'd have to wake up in the morning and a sign right now. So we would draw the sheets, pull them off to wake them up, to get them out, because they'll be depressed, sleep, and fatigued for a long time. The thing about cocaine and amphetamines and methamphetamines is that their withdrawal symptoms, unlike opioid, is not life-threatening. So people use them, they don't usually die, and they have these withdrawal effects that are really, really subtle. So a couple of other drugs. Let's talk about cannabis. Cannabis is legal in many states, but it's still a drug. And cannabis works by activating the CB1 receptors on the brain. And CB1 receptors have cause psychoactive effects. You know, you eat more, your cognition or your alertness is a little bit impaired. And if you smoke cannabis, your breathing can be slowed. So remember that. So CB1 receptors, bound by cannabis, they cause psychoactive effects. You feel mellow, right? But your cognition is impaired. Your thinking may be a little fuzzy. And then when you smoke them, you can get respiratory depression. The next class of drugs are called hallucinogens. This is LSD or psilocybin. Hallucinogens bind serotonin 2A receptors in the brain. They cause perceptual alterations. This is when people see green elephants. They see things that are really strange, right? They're see bizarre things. Hallucinogens are associated with minimal physical dependence and they have a low overdose risk. That's the one thing you should remember. Take a little pause here, and now we're going to talk about alcohol withdrawal. Alcohol is by far and large a most common source of substance dependence, only second to smoking or nicotine. And in withdrawal, there's a severity and timeline of alcohol, which is very characteristic. So at about 6 to 24 hours after someone starts drinking, they have mild withdrawal effects, meaning they get tremulous, right? You ever see them shaking? You see that they're sweating, they're anxious, they're nauseous, and they have a headache. At about 12 to 48 hours, this is when they start to see things. Like they start to see things that are not real, like, dead people, right? They have autonomic hyperactivity. When you do the vital signs, they're really tachycardic, right? They're really tachycardic and their blood pressure is elevated, and they become confused at 12 to 48 hours. I'm going to let someone in the room. Give me a second. Okay. And then severe withdrawal, this is when alcohol can get really life-threatening. So CNS stimulants, they don't cause life-threatening things, but alcohol can cause you to die. In alcohol withdrawal severe, which usually happens in about 12 to 48 hours, you can have seizures, right? You can have delirium tremens where you're basically look like you're psychotic, you're seeing things, you're reaching for things, you're all agitated, right? Your temperature goes up, you become hyperthermic, and yes, you can die. You can straight out die from alcohol withdrawal. So it's important for you to know the severity and timeline of alcohol withdrawal. And we like to keep people away from the severe withdrawal, right? And we like to pick it up with mild withdrawal. And you have to know mild from moderate from severe. And you have to know that with severe, it's about getting to the hospital quickly because they can literally die. In terms of opioid withdrawal, contrary to what most people think, is an uncomfortable withdrawal, but it's not a life-threatening withdrawal. Those people on the streets nodding, right? When they come off the opioids, they may feel uncomfortable, but they rarely die, right? It usually happens about 6 to 12 hours after using short-acting opioids such as heroin, because they're short-acting opioids, and it typically occurs 24 to 48 hours after using long-acting opioids such as methadone. All right, so 6 to 12 hours for heroin and 24 to 48 hours for long-acting methadone. The symptoms that you see with opioid withdrawal are anxiety, right? They get body aches, they get nauseous, they throw up, they have diarrhea, they defecate on themselves, they have insomnia, they can't fall asleep, and they're sweating profusely. With opioid withdrawal, there's usually a peak intensity at about 36 to 72 hours after they stop, right? And after you get over that peak, they gradually improve over 5 to 10 days, but it's usually not life-threatening. There's a thing called medication-assisted treatment. When patients are dependent upon opioids, what we can do is we can give them medications that stop withdrawal. We can give methadone. So the methadone clinics are well known, where people who are dependent on opioids will go into the methadone clinic and get it every day to prevent withdrawal. There's buprenorphine, right? One of the classes of medications is Suboxone, which is now given in the office, where someone can be on Suboxone, right, for their entire life. And basically it stops them from going through withdrawal. And what buprenorphine does is it binds those mood receptors all the time, giving a little bit of satisfaction, right? So they have a little bit of drug around all times, but buprenorphine, unlike fentanyl, is not life-threatening, right? And when you're in opioid withdrawal, we generally need to gradually taper the opioids and use comfort meds such as medications for nausea, right? That's how we treat opioid withdrawal. Moving on to the next withdrawal symptom, complex. Benzodiazepine withdrawal or alcohol withdrawal, very serious and complex, right? For short-acting benzodiazepines, they usually start to go into withdrawal in 1 to 4 days. For long-acting benzodiazepines, diazepam, they usually go into withdrawal about 5 to 10 days after you remove the benzodiazepines. Okay? They generally are used in high dosages. People can be on them for a long time. People can be on alprazolam for sleep for years and years and years. And when you take them off, right, they will seize, right? They will seize quickly because they're accustomed to that level of benzodiazepine. And when we treat a benzodiazepine withdrawal, you have to taper them slowly over weeks to months when they become dependent, right? Or you can substitute one benzodiazepine for a longer acting benzodiazepine, which essentially satisfies those receptors but doesn't cause symptoms. And this is a nasty withdrawal. With benzodiazepine withdrawal, people can have withdrawal for months, right? They can have anxiety, they can have sleeping difficulties for months and months and months. They can be agitated for months and months and months. Okay. Whenever you're dealing with substances, you have to know the signs and symptoms of overdose, right? So with opioid overdose, the first thing that you notice is that they have shallow breathing or no breathing. That's how you know you get a person who basically has overdosed from opioids, right? The pupils are small, right? You look at them, the pupils are small, they're knocked out, and they have blue lips and nails, right? So you immediately have to call 911 because they can stop breathing and then you can have brain damage. You give Narcan or naloxone, either by intramuscularly, intravenous, or do the nasal route. You have to bag them or do rescue breathing and turn them in the recovery position or lateral recumbent because they vomit. And if they vomit and they swallow their vomit, they can have aspiration pneumonia. So we put them on their side so when they vomit, they don't aspirate. One of the problems with naloxone is that it usually precipitates acute withdrawal, right? So when we give them naloxone, they usually wake up, they're agitated, and they're extremely angry at you because you messed up their high, right? So you got to have comfort medications ready because they're going to be nauseous, they'll throw up. Can't tell you how many times I've had to give Narcan and then rapidly give some Zofran so they don't throw up. In terms of stimulant overdose, meaning cocaine and methamphetamine, this is a tricky one. There's no specific antidote or reversal agent for stimulant overdose. This is why cocaine and methamphetamine is so hard, right? So we usually just use supportive care, meaning we put an IV in them, right? And we make sure that they're fluid hydrated, and we make sure that we put them in a room to orient them. They need psychological stabilization. In terms of stimulant overdose, you see severe hypertension. I mean, blood pressures of 220 over 140, right, in overdose. They're tachycardic. They have arrhythmias on the EKG. They seize. They have hyperthermic. They become very warm, core body temperature going through the roof, and they look psychotic. Again, you got to call 911. Excuse me. You got to call 911. You got to put them on a cardiac monitor, and we give benzodiazepines for managing their agitation and seizures. So we use one drug, another class of drugs to treat stimulant overdose. And sometimes they can become so hyperthermic that their core body temperature goes so high that we actually need to put a cooling blanket on them because that high temperature can actually damage their organs. So you see them in the ED on these air pressurized cooling blankets, right? And they need a lot of psychological support because they lose sense of reality. You always have to reassure them, and you have to put them in a safe environment. So those are the overdose syndromes. Let's talk a little bit about medication-assisted treatment, right? And this kind of relates mostly to opioid dependence. So there are 3 medications we use to treat people with opioid dependence. There's methadone, which is a long-acting synthetic opioid. We give it daily, and it has high retention rates. So people who use methadone, when you put them on methadone, they do well. They stay in treatment very well. You have to give it to them every day. Buprenorphine, or one of the medications in Suboxone, it's a partial agonist. It kind of binds that mu receptor. It has a very safe overdose profile, so you can't overdose yourself on Suboxone. This is why we've been using it. This is why this office-based treatment for opioid addiction by using buprenorphine, because you can stop people from going into withdrawal by giving buprenorphine, which binds the mu receptor, right? But they can't, no matter how much buprenorphine they take, they can't overdose. And that's why we've been able to move people off of methadone and prescribe it in the office. There's a couple of forms. There's a sublingual form and there's a film form. So you can give it sublingually, right, with a tablet under the tongue, or a film. And then there's naltrexone. Naltrexone is a complete opioid agonist. It knocks any other medication off the mu receptor. It disrupts their high. It blocks their euphoria. We can give it by oral or IV route. And with patients who go on naltrexone, they really have to have a very high motivation to stop using, right? So we only give this to people who we know have high motivation and a lot of reasons why they would be safe if they would try to use again. So in sum, the key takeaways from this lecture is that there are different substance classes which affect the brain differently. We talked about the different types of receptors, right? And that we need to understand that pharmacology, or the study of the medicine, guides our treatment response. That's the first point. Second point is that withdrawal severity varies. Alcohol and benzodiazepines, they have a strong withdrawal that's life-threatening, right? And they are really true medical emergencies. Opioid withdrawal is uncomfortable, but it's not life-threatening. People will go through a peak, and then over several days, they'll get better, but they won't die, right? And that overdose protocol is different by the substance that you're talking about. So naloxone is the antidote for opioids, right? And stimulant overdoses don't have an exact antidote, but they require supportive care when you put the IV in and you tank them up with fluids. The thing about medical assisted treatment is that it reduces illicit use. So the reason why we give methadone and buprenorphine, right, and naltrexone is that it simply just reduces illicit use, stops people from going out there and hitting somebody over the head for the drug, right? Stops them from craving. It improves retention, and so it improves their retention to care, and it decreases overdose mortality. So somebody on Suboxone, right, they give it out in Europe like candy to everybody, because they know that they won't die from it. We'll take a small break here, and I want to go over one case study. And so anyone who wants to answer this, you can open up your mic, and we're going to give the case of a client who presents with tremors, sweating, and anxiety for 24 hours, right? What kind of substance abuse is that? What kind of withdrawal effect is that? That is the withdrawal syndrome from alcohol, right? Everybody agree. Tremors, sweating, anxiety, that's withdrawing from alcohol 24 hours after stopping heavy use. And anyone. So in this case, what would you do? Someone's withdrawing from alcohol, what would you do? Unmic and tell me what you would do. Anyone? No one knows. No one has an answer to what to do with alcohol.
Get to a hospital right away.
That's right, Michelle. Get them to the hospital right away. Why is that, Michelle?
Because they can die. With alcohol withdrawal can kill you.
That's exactly it. Remember, opioid withdrawal is uncomfortable, but it's not life-threatening. Alcohol withdrawal, benzodiazepine withdrawal can kill you, right? Because those are the people who go into delirium tremens, they have seizures, and they actually die. Everybody got that?
They can also get a seizure before that.
They can get a seizure, yeah. They can get an alcohol withdrawal seizure, right? They can go into rhabdo, where they break down their muscles so much that they basically get renal failure from rhabdo, and I've seen that.
Delirium tremens.
Yeah, DTs. Really looking psychotic, agitated, grabbing for things, seeing stuff in the air like they don't see, seeing different colors, totally looking confused. Yeah, and their vital signs, they're very hypertensive, they're tachycardic. Yes, that is delirium tremens. So with that, I want to open it up for questions. Anybody have any questions about what we discussed today? I want to, and you know, we're done today. You all did this very well. But I want to go over anything that's not quite understood. Any questions?
The different receptors.
Okay, so we're going to go over the receptor again. There's GABA receptors, right? Which are the way that CNS depressants have their effect. They bind to GABA receptors. There's mu receptors. That's how opioids have their effect. There's CB1 receptors. That's how cannabis has its effects. And there's serotonin 2A receptors, right? Right? So remember your receptors. And then there's a class of medications, the CNS stimulants that act by increasing dopamine, norepinephrine, and serotonin in the brain. Any other questions? Any other questions? I'll give it some time. Any other questions? Any questions? And remember, you got to remember these withdrawal symptoms. You got to remember withdrawal versus overdose. Withdrawal versus overdose. You got to remember which drugs cause tolerance really quickly, right? You got to remember your agonists and your partial agonists and your antagonists and your receptors. If you get those things straight, you'll be really set in terms of being a great substance abuse counselor. So at this time, what I want to do is, because we have the pleasure of having Kim Best with us, I believe. She may want to share a word or two about where we're going with this class. Kim, Dr. Best.
Hold on. Good evening, everyone. Good evening. Yes, well, our focus is to do the KSAP, get certified, and begin our work in the communities. And this is what we set forth from the beginning. And I want to thank everyone for participating in the KSAP. I have to be honest, it's been so crazy. Beginning in the January, well, really the end of December into January, with so many things happening. But I wanted to make sure that I can at least attend all of them, all of these meetings, but I didn't miss about 2 or 3 of them, didn't I?
Only 2.
Only 2. Okay, well, that's 2 too many. Okay, but I want to welcome everyone here on this study, and hope to see everyone at to get certified in April. Great. Is that April?
Yeah, in April. So this class is sort of like reviews all of the topics for the exam, but it's not the class that the state uses. So unfortunately, all of us have to enroll in Stony Brook so we can take the official classes and knowledge. At some point, we'll use our class and we'll submit our class as the official class, so you won't have to take Stony Brook. But the good thing about this class is that you're going to review the kinds of things that you need to for the test. So when you start Stony Brook, you'll already be well ahead of the game. Okay, I want to ask a few people that are here about their sort of experience thus far. Is Denise here?
I am.
So Denise, okay, so you're here with us, and we appreciate you being here with us. What are your thoughts about particularly where we're at in this lecture in particular?
I think it's a good gateway to keep us educated while we are awaiting next steps for submission of the essay, and then preparation of the final exam, which can you confirm? I believe you said it was April?
Yeah, so the Stony Brook class opens in April. And actually, most people take the exam after that class is over, because when you get through that class, you will have already done this class and you'll see all their lectures and you're already studying. But as you know, an indeterminate amount of time after that, you can take the exam. And when you pass the exam, you are a KSAC in training. And the good thing about being a KSAC in training is that you can actually be you can actually work and you can actually bill for services.
Now, let me ask, so I have two questions. My essay is complete. Am I supposed to email that over to the contact that Virgil provided for Stony Brook now, or are we submitting that as a group?
You submit it now. So we
Okay.
want everyone to submit their essays to Stony Brook so that they can be enrolled in the class.
Okay, and then once I'm not really clear on once we're either enrolled in the class or once we've completed the class, will we still have availability to work through your services for like the hands-on?
Exactly. So you go from a CASEC-T to a full CASEC by getting clinical hours. And the good thing about this class, unlike most, is that I can give hours for with patients that I use through my practice. So what we hope to have is some contracts, and I can tell you about that much later, that has ample amount of work for you all to work on patients who have substance use disorders. I want to now go to Michelle. Michelle, in terms of real life scenarios, what can you share with us?
Well, I was kind of laughing when you were talking about all the symptoms of the different drugs because I went through all of them. I was, the auditory hallucinations with coke, the paranoia, the anxiety. It was awful. And with alcohol, the withdrawal, I went to 3 detoxes. So luckily I got into detox in time, but I was so sick. It was just so sick. And, the LSD, I did like everything pretty much. I snorted heroin. And that was like, I stole the morning shot from my boyfriend. It was like I was addicted. And that's what you do. You steal, you lie, you do whatever you have to do. But so many of those symptoms just resonated with me. And I'm so grateful that I'm not there. I'm so grateful I have space between that and now.
So when you were going through these symptoms, what can you remember about the substance abuse counselors that you ran into in terms of who were the good ones, who were the bad ones, and any thoughts about when it was done right versus when it was done wrong?
I don't remember any substance abuse counselors. That was a long time ago. What I do know is I would go to rehab for my boyfriend with the bottle in my bag and reeking of booze, and nobody said a word. And I did it again and again and again. And nobody said a word, which really surprised me, even in the condition that I was in, So I think it was very different 40 years ago in terms of helping alcoholics and addicts.
Were there people that dealt with you from a morality basis, were shaming you versus understanding that this was a biological dependence?
I didn't really get shamed. And I've always wondered about that because I've heard that so much, that it's, it's a moral thing. So many people think of it like that. When I got sober, I told everyone I was a recovering alcoholic. Whether or not I should have, I don't know, but I didn't get any bad reactions, which I'm very grateful for, because that would have been so shaming, but I felt like I had to tell you so that I would stay sober, like it wasn't a secret. And I know a lot of people who don't do that. They keep their anonymity and, never tell people that they're sober, but I was very lucky with that experience, not having people shame me. I was very lucky.
Yeah. In some ways, substance use disorder is very hard for people who have a life where they're respected. Someone who's popping hydrocodone because they're opioid dependent, it has a good job. They keep it a secret because they don't want people to know, and because they may be protecting their job. Have you seen that?
Oh, definitely, yeah. I even did that to a point, like when I was using, I certainly wouldn't tell anybody what I was doing. I was hiding my bottles. I was hiding the drinking, drinking in bathroom stalls and, away from anyone. But I also know people who did that they were hiding it because they had to, because they needed their job. And I think what ends up usually happening is they can't hide it anymore at some point. and their job either has a program they can go to, which is like a huge gift, or they get fired.
Yeah, yeah. So one of the things about medication-assisted treatment, and this is a kind of a weird thing, is that we're treating conditions really to keep people from the consequences of the substance. You know, so Suboxone is an opioid, right? Now naltrexone is actually an antagonist, and methadone is an opioid. So what we basically did when we gave people these medications, and I'm not saying it was a bad thing, was we stopped some of the consequences of opioid use, such as having to go out in the streets, craving and beating somebody over the head or stealing. So basically, we just keep people out of correctional settings. And one of the things that I saw when I worked in corrections, that there were so many people that basically didn't quite follow the program when it came to Suboxone. What they would do is they would get out, sell the Suboxone, and go get some fentanyl, right? And I never understood why that was the case, why someone had a drug that would keep them calm and keep them controlled, right? And they can get it from an office. Yet when they got out, even given a prescription of Suboxone, why they would go out and use some fentanyl or heroin. Do you have any idea, Michelle, why people do that?
I think they want to get more high. I mean, I think, you know, it's not enough. It's just they are not ready to really recover. That's just my gut feeling. I don't know if I'm right or not, but you know,
I think you're absolutely right. Yeah,
I think I would do it. You know, if I weren't ready, I would probably do that too.
Yeah, and so what we find out about our use with office-based treatment is that the medications are only part of the solution.
Right.
They're only part of the solution. So you got to reach out to the mental, right? You need counseling. You need those kinds of things. And lastly, the reason for this course is that you have to reach out to the spiritual. Sometimes people get to a point where they have no reason to live. They're just living for the substance. And that becomes a spiritual matter. And that's when, you know, people who do substance abuse counseling classically, where they lose ground and they don't know how to talk to a person, right, who basically has relapsed a lot of times, or who basically has gotten into a cycle or socio-cultural situation where this is their life. When they go around the block, they go right back into it, and they get into a cycle of the things that they know and they can't get out. That's a spiritual thing. And so the reasons for this training as a KSAC and as a chaplain is to really address all of that and not to be incomplete. Because sometimes, particularly when people are recovering, we forget to have the question about who are you? What makes meaning in your life, right? What is it? Who is the God that you serve? And those kinds of things that really reorient people. And a lot of times what I saw when I was treating people was that they never got better until you looked into their core belief system.
Mm-hmm.
Some people who had been using for years and years and years, at some point they turn around. And why they turn around is usually they come to sort of a spiritual awakening. Like, wow, you know, who am I? You know, my whole 10 years spent doing this. You know what I mean? My relationship with my family ruined. My relationship at work ruined. I don't have any job anymore. And who am I? Where am I? And why am I even walking around the planet?
Yeah.
So I want to pose that question to Apostle. Is Apostle Valentino on?
Yes, sir.
So can you tell me a little bit? Have you ever seen people who are at that place where you need to pray for them because you realize that, you know, it's really hard to get them off stuff when that's all they're living for?
Yes. Saw it many times. I remember one guy, especially in Eastern York when I was in the church. You know, he was heavily on alcohol. But every time he would come upstairs and sit in the sanctuary, I would sit with him and just try to encourage him and talk with him, you know. And to see somebody want to reach out, but their addiction got the best of them, but they still trying to stretch themselves forward to get God to help them. You know, it is a sad thing. It's a hurtful thing. It brings out the compassion in you. You don't mind sitting next to that person for the whole service, even if they get a moment of freedom. You're happy.
So tell me your thoughts about when did they realize that alcohol is not the God, but there's actually a God that's higher than alcohol?
I guess after they, going through all that they're going through, I think that's just a deep spiritual thing that people just, automatically knows, but we tend to suppress. It's just that I think it's that God-given, built-in. We're born with that. We're understanding that someone is higher than us always. So I think that's what brings a person back to be grounded and to continue to reach out in spite of their addiction and their hurdle that is before them.
That's very interesting, and I agree with that. Apostle Allen.
Yes, sir. Okay. Can you hear me, sir?
Yeah, we can hear you.
Okay. All right. Yeah, I was just listening at Apostle Valentino, and even you taking us through the chart, and I had a tough experience. My mother, I watched her turn into an alcoholic, and from a child and child and teenager, it was pretty rough. It was a rough experience. I didn't understand it. I just knew one thing, that alcohol wasn't good for her at all. Because it changed her. It changed her behavior. It changed who she was, and in spite of me yet loving her. And she started, like Apostle Valentino, she started reaching out from within. And, that soul part is greater than any addiction, and individuals like that, I found that they need a lot of attention. They need love. They need to know that somebody else cares to help them fight the battle from within. And it is being between a rock and a hard place, that's for sure.
I think one of the things that's very important when people have reached that point is for them to understand that they have self-worth and they're loved by God.
Yeah.
It's too often what we do is when they get into the cycle of addiction, we throw them away, we talk about them, we get angry, we kick them out, and those like things. So they'll never come back until they get that spiritual awakening that they have self-worth and they're loved by God. And so the meaning of what we do is slightly different, because we get people to realize that they have something to live for. So what I usually do is, I told you all before, is I draw those family trees, and sometimes I start talking about, like, what are your goals in life? What are things you wanted to do? And to remind them that their goals and achievements are still real, that they haven't lost it all. And that's the most effective way of bringing people back. You really got to love people. You really got to respect people to be a substance abuse counselor. And if you're not like that, if you really don't lean towards people, you really don't see the inherent worth that they have, if you don't see that they're loved by God, then if you don't do that, then you really shouldn't be, and I mean, be serious, you shouldn't be a KSAP. Right? So, and that's another reason why we draw spiritual people to this, because it takes that type of person to really do the work. And a lot of times people get that perspective because of a sense that they received themselves blessings that they didn't deserve. Chaplains are kind of funny people, but most of them have gotten to a point in their lives that they're helping other people because they got to the point in life where they said, this good thing happened for me, or I was uplifted, and it was about nothing that I could do on my own, that God just reached out for me and helped me, or some person saw the God in me and reached out to me. Who's raising the hand, or something's in the chat? So, with that, I want to say that this has been really, am I still there? Yeah, this has been really informative. If anybody else has anything to add, please do so. Okay, so without further ado, we'll meet next week at 6 or 7. That's our time. Michelle, I want to thank you. We want to give thanks to Dr. Williamson. She's sick tonight, but she'll be back next week. We want to thank her for her putting this class together. It's really good music. Has everyone gotten the learner's manual?
Yeah.
And I think Mr. Holloway has his hand raised. Mr. Holloway, I'm Mike. And I see something in the
I got the
chat.
manual. I got the manual. That's all
Okay,
set.
so everybody got the manual. Please go through your manuals. This gives you a way to review the stuff we've covered thus far. It's also a good study aid for the eventual exam. Without further, we got about 5 minutes to 7. We're a little early, and I want to say thank you to everyone for staying persistent with us. And if there's anyone that's not here, please reach out to them and tell them they need to get on this because we're moving forward. Thank you, and God bless.
I just stopped the recording.